Good morning, everybody. Thank you for coming, and by the way, Happy New Year to all of those that I haven't seen yet. It's hard to say that February 1st, but, this is our first program of the year in Miami. We've done a few other programs already. For those that don't know, for those who've never attended our programs, my name is Stuart Schlossman, President and founder of MS Views and News, and again, we do thank you for coming. Last year, we did 30 programs in the state of Florida. We did our first program outside the state of Florida when we got into Atlanta, Georgia. This year, for those that use our website, on the right side of the page, you can see a listing of all the programs we have planned from now until June. And if you take a look later on, because you can't see the whole screen, if you take a look by going to our website, you'll see that we still have about 17 programs to do between today and June 7th. And this is made possible by what we are doing for the MS community. The pharmaceutical companies have recognized what we're able to do. They see the outcomes. They know the programs that we're providing and how it's benefiting all of those affected by multiple sclerosis. So in addition to these, with these 17 programs that we have still to do, we're also getting out of Florida again. We are going to be in Birmingham, Alabama in April. We are going to be in Charlotte, North Carolina in May. We are going to be in Atlanta, Georgia again, but we'll be there in June. Then we're going to be planning for the second half of the year, where we hope to get into South Carolina, maybe back into another section of Georgia, and maybe again back into Alabama, as well as all the programs that we're doing in Florida. Before I go further, I want to thank Teva Neuroscience for providing us with the charitable sponsorship that we needed to do today's program. And I would like everybody to say thank you. Thank you. There you go. In addition to Teva Neuroscience, we also want to thank our other sponsors. That would be Accorda, Biogen IDEC, Genzyme, a Sanofi company, Novartis, Questcor, and Neuroscience Centers of Florida Foundation. We'd like to thank all of them. Thank you. I also want to thank our volunteers that we have assisted all of our programs, the MS Views and News staff board members that make their time to come out to our programs as well. Many times we ask people that we know whose children need their community service hours for high school, and we ask them to come out, and we'd like to thank them for being at our programs too. For today's program, we will have Dr. Berta Fonseca speak about emerging therapies, MS relapse, and symptom management. And then after Berta Fonseca, we're going to have a special guest come up that you all will meet, for many of you, for the first time, and we'll announce her later on. Also, Dr. Rick Harris is here. He's a psychologist. He'll be speaking about the impact of MS on the family. Why? Because multiple sclerosis does not just affect the patient. It is, and it does affect every member of the family. And we want you to hear how these family members could get more involved, how we don't want you to feel too much of one thing or enough of another, and that will all be explained by the psychologist, who we're going to have to get him to speak up and speak loudly. And for those of you all the way in the back, if you can't hear him, he speaks softly. Just tell him to speak louder. Okay? Thank you. That's him over there. So, just so you all know, MS Views and News is not part of the National MS Society. This is our program today. We don't do anything for the National MS Society, or they don't. Again, we're a separate organization. There are a lot of people out there that don't realize that there are different MS organizations. The MS Society has their reasons for being, research being number one, which is great because we always do need somebody to head up what's going on with research to eventually, hopefully, find us all a cure for what we're living with. And by the way, there are those out there that don't know, I too have MS. Yes, and I do all this for everybody because I found that there was a need for it. on the screen right now, you can see behind me, there's that list of events that is happening on the right side of the screen that's going on through June 14th, which will be our symposium in Orlando. Just because you live down here doesn't mean you can't go to a program that's taking place in Fort Lauderdale, Orlando, make it a vacation. Jacksonville, who knows? Okay, you want to go to Birmingham? We could use you there too, all right? They need to see what it's like living in South Florida, so come on up. So anyway, though, I just want to get things along here. I wanted to show you our website. We use our blog. We do Blog Talk Radio every other month. We have our YouTube channel. For those that want to see this program afterwards, you'll be able to watch it on YouTube. It's youtube.com/msviewsandnews. And all of our programs that are now being video recorded are all found on the YouTube channel. So if you know anybody living outside the area or even down here that could not attend today's program, again, you can watch the entire program on that YouTube channel. Again, please turn your cell phones to vibrate. Okay, so without any further ado, let's get started with Dr. Berta Fonseca. Thank you for coming here today, and we'll continue after you.
Okay. Alrighty, so good morning. As I said before, my name is Dr. Berta Fonseca, as Stuart mentioned. So today we're going to be talking about multiple sclerosis symptom management and treatment options. Alrighty, well, first of all, I'm sure that the majority of you are familiar with what multiple sclerosis is. It is an autoimmune, chronic, neurological condition where the myelin, or what the protein that covers our nerves throughout our body and our central nervous system, particularly the brain, optic nerves, and spinal cords, is damaged or destroyed. These lesions can cause interruptions in our electrical circuits that we have, and therefore, by causing these short circuits, the impulses don't run as smoothly, and that can present some of the symptoms that can happen in multiple sclerosis. It is unpredictable. It varies from person to person. Symptoms can vary from something very mild to something more severe, depending on what part of the central nervous system they affect. It is not directly inherited, which many patients have that question, and the majority of patients have a normal or near normal life expectancy. The exact cause of multiple sclerosis is not known at this point, but we believe is multiple factors. For example, environmental, a genetic predisposition, sometimes a viral infection like the most commonly known, the Epstein-Barr virus, or the virus that causes mononucleosis, usually develops between the ages of 20 and 40, affects more women than men, and there are approximately 400,000 patients in the United States that are diagnosed with multiple sclerosis. There are different types. There are different types of multiple sclerosis. The most common, with approximately 85% of the patients having the relapsing remitting, whereas where a patient will have a relapse or a flare-up or an attack, and then they will recover and go back to their baseline. Then there's a primary progressive type, which only affects 5% of the patients. That since the beginning of the condition, there's a steady worsening and more symptoms accumulating. Therefore, there's a steady progression of the disease. The secondary progressive, which affects approximately 10% of patients, is where you can see and start off as a relapsing remitting, but then after several years, 10 years, for example, if that patient has not been on treatment, then they develop a more progressive disease where they no longer have relapses, but rather a steady progression. And that's the secondary progressive. And then there's the primary progressive, which is primary progressive, which is basically the primary relapsing. I'm sorry, I don't know why I put that. Been a mistake, but it's a primary relapsing when there is progression, but at the same time inside the progression there are relapses. That's the least common one that we see at this point. Some of the common symptoms in multiple sclerosis patients are just a couple of them, as you can see here, that we're going to be discussing a little bit more in detail. The weakness and numbness in the limbs, hands or legs depending, disturbances of vision, cognitive changes, fatigue and tiredness, bowel and bladder dysfunction, and disturbances of walking or balance. So we're going to cover these a little bit more in detail. We know that there are more symptoms as well. First and foremost, we're going to talk about the weakness and numbness in limbs. There can be weakness and numbness in limbs depending on what part of the central nervous system is affected. depending on where the lesion is or the attack happened. That's the kind of symptom that the patient might have, and then therefore have more problems regarding issues with the strength or the sensation of his or her limbs. It is one of the most common symptoms, and these symptoms, if they're to a degree where they're quite severe, they can interfere with a patient's life and cause a decreased ability to function and to use the affected limb. For example, weakness and numbness in the arms can affect your ability to write correctly or to hold objects such as feeding utensils. Weakness and numbness in the legs or in the lower extremities can lead to difficulty or inability to walk or use that extremity that's affected. And it is usually assessed in the neurological examination, healthcare professional. And that way we have a better idea of what's causing the problem. In some cases also, numbness or lack of sensation in the lower extremities can lead to a lot of difficulty walking, such as imbalance, because the brain cannot pick up that information since the nerves are weak. In the case that the symptoms are related to an exacerbation or to a flare-up or an attack, that patient can receive treatment with IV Solumedrol, or which is the methylprednisolone, or the Acthar, which is also approved for treatments of MS exacerbations. Other patients are candidates and can benefit maybe from occupational therapy, physical therapy, depending on their symptoms, obviously, since they vary. The next symptom that we want to discuss is disturbances of vision, which is quite common. Approximately 50% of patients might experience at some point an optic neuritis, which is an inflammation of the optic nerve that leads to a temporary blurriness or loss of vision associated with pain on eye movements. So that is very important to if you ever have that symptom, to discuss it immediately to your healthcare provider, since they need to be treated with IV methylprednisolone or Solumedrol or Acthar gel to those that are intolerant to the Solumedrol. And at some point, a neuro-ophthalmologist should evaluate that patient to make sure that there's no more damage associated to that exacerbation leading to an optic neuritis. Another very common symptom is the cognitive impairment that can see in 45 to 65% of the patients, more of a milder to moderate style, but in 5 to 10% of patients, they can have severe dysfunction. Cognition is our process of thought and our memory. It also has to do with our memory and our ability to remember things. And disability and disease duration are not good predictors of cognitive dysfunction. So not necessarily because somebody has had MS for a longer period than another patient, it necessarily means that their cognition will be worse. They're not related. There are certain areas of the memory, of the cognition, that are more affected in MS patients. These are the recent memories, which is the short term, what we did yesterday, what we ate this morning, things that have happened recently. Our verbal fluency, which is the ability to speak fluently. Abstract reasoning. Sustained attention, which is also what we know as multitasking, trying to do 2-3 things at the same time. And also the concentration can, in some cases, also could be affected. What's the etiology, or what causes this cognitive impairment? We believe it's in the extent and the locations of the lesions, particularly those patients that have a bigger load of T2 lesions, or maybe that they have it located in the frontal lobes, also can be more at risk of having more cognitive impairment. Also the degree of brain atrophy or shrinking of the brain, the more atrophy there is, the more at risk that patient is of having cognitive problems. And also the T1 black holes, which also, the more black holes a patient has, those are little holes, that's said, in the brain, and that could also predispose that patient to having more memory loss and memory issues. It is super important not to attribute the memory just to MS. There's other things that can happen and other medical conditions that that patient might have concomitantly that can also alter or affect their memory. For example, depression is very important, since it's the most common type of false memory loss or pseudodementia, as it says there, and obviously it's treated differently. Stress, fatigue, which also affects our patient's ability to concentrate and perform accordingly. Medications, some of them very commonly used, like baclofen, Neurontin, clonazepam, which are medications that many patients are on for muscle relaxant or for pain or for anxiety. And also sleep disturbances such as obstructive sleep apnea, which we see a lot in MS, and can also affect your memory and your cognition. There are several medications that are approved for memory loss in other types of patients, but unfortunately they have failed to show benefit in the treatment of multiple sclerosis-related cognitive problems. So the most important thing is that, since it's mentioned here, is to be on a FDA-approved medication for those that have relapse-remitting multiple sclerosis. Some small cognitive strategies, small tips that maybe you can consider, which I usually recommend, is to write everything down. If you fear you might forget something, just write it down to remind yourself. Have a designated space in the house to put the most common things that are lost, for example, the keys. Repeat things that you need to remember. Take your time. If you find that your memory is most affected at a certain part of the day, we'll arrange your activities around the time that you feel you're more able to concentrate, more awake, and more that your memory is better, and also focus one thing at a time. Most important, if you ever suffer from any of those problems, make sure that you tell your healthcare provider. He or she can certainly help with that. Now, the most common symptom, and also the most disabling one, is fatigue, affecting 80% of the patients, as is mentioned here. And it basically consists of a lack of strength, a lack of energy, tiredness, just generalized weakness that patients might feel. It can be more pronounced in patients that have more atrophy or shrinking of the brain, particularly in the parietal lobes, which are the ones here up top. But also, other causes must be excluded, as we were saying before with the memory. Depression can cause fatigue and tiredness. Insomnia or inability to sleep. Obstructive sleep apnea, also a common cause of fatigue. Thyroid problems, we have to check for that. Hypothyroidism can lead to a lot of tiredness and fatigue and lack of energy. Medications, the same ones that we mentioned before, muscle relaxants, anti-anxiety medications. Vitamin deficiencies, vitamin B12 sometimes is also a common cause. And anemia, which is, these last ones are easy to check with regular blood work. Now, the treatment of fatigue, if we find a cause for it rather than just MS, vitamin deficiency or anemia or thyroid, then we treat accordingly. But if the fatigue is associated to the multiple sclerosis, there are several unapproved treatments that in some cases we can use if there's no contraindications, like amantadine, Provigil, and Nuvigil. Non-pharmacological treatments for fatigue, for those that prefer to treat it more naturally. Well, conserving energy, taking naps throughout the day really helps. Arranging activities, again, to be done during the part of the day that you have the most energy so that you can get the most out of the day. Staying away from the heat, which we know is crucial for MS patients. Staying hydrated, eating healthy. For those that can, exercising as well will help. Another common symptom that we could see sometimes in some patients is bladder dysfunction. Some patients might experience issues with their bladder, and there's different types of bladder problems. One is the spastic bladder, or is the bladder that has a failure to store because it's very, very tight, doesn't expand accordingly like it should. Bladder with a failure to empty, which is the bladder that just keeps accumulating urine and urine and urine, and the patient cannot go to the restroom and urinate normally. Or the conflicting bladder, which is the bladder that's squeezing, trying to push the urine out, but then the sphincter, which is the muscle that controls our ability to urinate, doesn't really relax. So that patient is having difficulty because he or she cannot urinate appropriately. There are several symptoms that you could also suffer or see, which is the frequency and urgency of urination, hesitancy of urination, you're trying to urinate but you cannot, inability to completely empty your bladder, which in some cases can predispose to having urinary infections, inability to hold urine, that can lead to accidents, and the frequent nighttime urination, which then interrupts your sleep, fragments your sleep, and doesn't let you rest. If you ever experience any problems with related to your urine, you should discuss it with your healthcare provider, because he or she can refer you to maybe a urologist for urodynamic testing to see if they find the reason for that urinary problem, and do ultrasounds, etc., just to rule out other potential things. Make sure that if the bladder is something that's bothering you, bladder dysfunction, stay hydrated, even though it sounds counterproductive. Just make sure that you don't sip water all day long. Just right after a certain time of the day, don't drink any more water, so that you can then hopefully sleep at night without any interruptions, and avoid caffeine, because caffeine is a diuretic, and make sure that ever so often you go to the restroom, you can urinate, and therefore not have the problem of having to last minute rush, and then if you happen to maybe have a walking impairment or something, then there can be accidental loss of urine. So there's also medications approved for overactive bladder. Obviously depends on each patient, so it's something that if you experience, I encourage you to talk to your healthcare provider about that. Another common symptom will be bowel dysfunction, which some patients might either experience severe constipation due to medications, lack of hydration, lack of physical activity, or incontinence, which is the accidental loss of stool. Some tips that can help you with, primarily with constipation, is making sure that you stay well hydrated, that you eat high fiber diets, maybe stool softeners in some cases, bowel program to sort of train your bowel to go around the same time every day. And in some cases, there are medications that can help with severe constipation. And also last but not least, disturbance of walking and balance, which is also a very common symptom that some MS patients can suffer from. And some patients might present different issues that can affect their walking, including imbalance, unsteadiness, weakness or numbness of the legs, as we were saying before, slowness, frequent falls, foot drop, or any other nerve injury that could put them at risk for falling and making walking more difficult. Your healthcare provider can certainly assess for different causes of the walking dysfunction. In some cases, the imbalance and the gait unsteadiness, patients can benefit from physical therapy that can basically focus on gait training and also on balance exercises. And in the case of weakness, obviously physical therapy can certainly help with re-strengthening those weak muscles in order for that patient to walk better. In some cases, for those that they feel their walking is very slow, and if they do not have any contraindications to the medication, there is Impera, which is a medication that's approved by the FDA for MS patients that have difficulty walking. Basically what it does is sends the nerve impulses to the legs faster, therefore patients feel they're able to walk faster and with a little bit less effort. Again, there's certain contraindications, so it really depends on each one-to-one patient. In some cases also, patients might have maybe like a foot drop or some sort of nerve injury to the lower extremities that can make their walking much more difficult. And in some cases, they can benefit from assisted devices such as an ankle foot orthosis or an AFO, walking canes, or maybe a walker to prevent maybe from falling and having other complications. Another symptoms that some patients can experience is dizziness, vertigo, which we always have to make sure that the inner ear is fine, so always an evaluation by an ENT is a good idea. There are medications to treat dizziness and vertigo, like for example meclizine. Some patients might experience difficulty with speech, so always speech therapy is extremely important. For those that have difficulty swallowing or choking, also speech therapy, and there's specific tests like the barium swallow, etc., to assess to make sure that whatever you're choking on is not going to the lungs, because then that could lead to a pneumonia and to even more complications. In the case of those that suffer from spasticity or muscle spasms or cramps, there are medications also for that, the muscle relaxants, which have been around for a while, and they do help significantly, specifically for those that have painful muscle spasms at night that won't let them sleep. And then there's also neuropathic pain, which is pain related to nerve injury, which is very bothersome, a lot of burning, in some cases tingling, and there are medications approved for neuropathic pain that can really help with those symptoms. So all these things just to keep in mind. Now that we've talked a little bit about some common MS symptoms and symptom management, I would like to go into what is a relapse, which is another topic that we wanted to cover today. A relapse, which is also known as an attack or an exacerbation or a flare-up, is basically neurological symptoms that have been going on for 24 hours or more and are continuously progressing or worsening, and are at least 30 days apart from the last relapse. So that is what a relapse is. Most relapses can last anywhere from days to weeks, and some can be new symptoms that just happen or worsening of old symptoms that you had before. Some of them can be just one symptom. For example, optic neuritis, just loss of vision out of one eye with pain on eye movements. Some other relapses that are a little bit more. For example, somebody that developed a transverse myelitis that they don't feel from their belly button down, and then maybe they have also a weakness and lack of sensation, and maybe some bowel or bladder issues. So some of them have just one thing. Some of them affect more functions, and it's always related to what part of the brain or the spinal cord that relapse affected. It is caused by inflammation of the central nervous system, as I said before, either the brain or the spinal cord. And it is important to differentiate between a true relapse and a pseudo-exacerbations or a false relapse, which are pretty much appearances of brief appearances of old symptoms, not related to new damage in the CNS or central nervous system, and they're mainly caused by maybe if you have an infection like a urinary tract infection or a pretty bad cold, overexertion, maybe overdoing it while you exercise, increasing your core body temperature like going out in July at 100 degrees, and also just being out in the heat. All of these things can trigger or bring back old symptoms, and then the patient might think that they're having an exacerbation, but they could be, in some cases, false exacerbations. So we have to make sure to keep that in mind and discuss it with your healthcare provider to see what's best to treat. Obviously, if it's an infection, the cause, we treat the infection. If it's overheating, we make sure that you cool down. Maybe you use a cooling vest when you go outside. Avoiding dehydration, etc. So some things are obviously easier to help. Some mild exacerbations or true exacerbations can be. Not necessarily do we have to treat all exacerbations. As with everything, we want to make sure that the benefits outweigh the risks, and we don't want to be giving medications for just anything. So there's some exacerbations that we just let it heal on its own, and we don't have to give them medication. But for more severe relapses that obviously interfere maybe with the patient's life, we can give them IV methylprednisolone, which is the Solumedrol, anywhere from 3 to 5 days. And basically what these corticosteroids do is reduce the inflammation and help speed up the recovery from a relapse. Now, also, besides the IV Solumedrol that's been around for many, many years, we also have the Acthar gel, which also stimulates, how it works is by stimulating the production of our own natural steroids. And it is also approved for treatment of acute exacerbations in multiple sclerosis. And it's basically an option for those patients that maybe don't tolerate steroids or have had side effects to steroids. Maybe those patients that have poor venous access, they can find a vein to actually put the IV for the Solumedrol, or maybe have been unsuccessful. They've been on steroids before for their exacerbation, they really haven't recovered as expected. So all those patients are great candidates for Acthar gel. Now, going a little bit more into the available treatment options for multiple sclerosis, as you are well familiar with all the treatments that we have approved so far by the FDA for the relapsing types of multiple sclerosis, which are anywhere from Betaseron, which was the first one in 1993 to be approved, Avonex and Copaxone, who came around in 1996, Novantron, Rebef, which started here in the United States in 2002, Tysabri, Extavia, Gilenya from 2010, Albagio 2012, and Tecfidera being the last one approved in 2013, so less than a year ago. Now we're going to talk a little bit about them. Ooh. I really did something here. Here we are. Alrighty, so first we're going to talk a little bit about Copaxone, as I said before, approved in 1996 for relapsing MS. Before, it used to be a medication injected subcutaneously, 20 milligrams every day, but since January 28, 2014, so 4 or 5 days ago, the FDA approved, based on the GALA trial, which was a trial that was done and presented to the FDA last year, Copaxone, 40 milligrams, subcutaneously 3 times a week was approved. So that's a great, that will be a great benefit for many patients that have been on Copaxone, injecting every day, and have suffered some side effects from it, from like lipoatrophy, etc. Now they have that option to go on the 40 milligrams 3 times a week. So it's great news for MS patients. Basically, what Copaxone does is believed to cause a shift from the Th1 inflammatory cells to the Th2 anti-inflammatory cells. Some of the common side effects that you can see with Copaxone is the lipoatrophy, which is a little bit of denting in the skin in the areas where patients have injected. Injection site reactions, which is the area will get red, a little bit swollen, painful, uncomfortable, bruising, and post-injection reactions, which can happen in a small amount of patients as well. So then Copaxone is by itself. Then comes all the interferons, which are also all grouped together. We have Avonex, which is 30 micrograms intramuscularly weekly. We have Betaseron, which is 0.25 milligrams every other day. Xtavia is also 0.25 milligrams every other day, which is about the same. It's the same medication as Betaseron. And then we have Rebif, which is 22 or 44 micrograms 3 times a week. They are immunomodulators, very important. They're not immunosuppressors. They don't suppress your immune system. The exact way they work, it is not known, but they have been approved for a while for relapsing forms of MS only. Now, some of the common side effects that you could see with some of the interferons are the flu-like symptoms, which are generalized pain, discomfort, like chills, headache after the injections. In some cases, depression and anxiety. Injection site reactions also as well, redness, swelling, bruising in the area where you injected. Liver problems, we have to follow up the liver enzymes. Decreased white blood cell, decreased hemoglobin, which is basically anemia, or decreased platelet count. Thyroid problems, and they do pose a risk to pregnancy. They're all category C. The only one that's a category B is Copaxone. Category C meaning that there's a risk of fetal harm or miscarriage with the interferons. Copaxone is the only one that's the category B. Another treatment option, and probably the most effective, is Tysabri, which is a monoclonal antibody. It is given intravenously every 4 weeks at an approved center. It's approved for relapsing forms of MS as well, and it basically hampers the migration of cells from the immune system into the blood-brain barrier into the central nervous system. So basically blocks that entrance of immune cells or cells from our immune system going into the central nervous system and attacking it. It does slow the worsening of disability and decreases the number significantly the number of flare-ups. So it's probably the most effective medication, but again, it's not for everybody. Some common side effects are allergic reactions, headache, infections, respiratory urinary tract infections, tiredness, fatigue, depression, liver problems, and also it does increase the risk of progressive multifocal leukoencephalopathy, which is basically a massive demyelination of the brain that if it's not really caught in time, it can lead to death in some cases, unfortunately. Another medication, actually the first pill ever approved for MS, which was back in 2010, was Gilenya or fingolimod. It's a dose of 0.5 milligrams daily, once a day. It basically sequesters the lymphocytes, which are part of our immune system, or cells that go and attack whatever foreign bacteria or virus has come into our body. It sequesters the lymphocytes in the lymph nodes, preventing them from moving then into the central nervous system. It significantly reduces the annualized relapse rate and also slows down the disability progression. There are some side effects, for example, slow heart rate or bradycardia, and also increase in blood pressure. So therefore, for the first dose, the patients need to be monitored in a clinic or in a center. They do increase the risk of infections. Also, we have to check for the liver, for potential liver problems. It can lead to edema in the macula or the back of the eye that could lead to some visual problems. Basically, there has to be an ophthalmological evaluation before starting the medication, and therefore, after that, 4 months afterwards, to make sure that that patient hasn't developed any sort of edema of the macula. In some cases, can lead to headaches, and there was one case of PML described in Europe. Another oral medication that came out in March of 2013 was Tecfidera, formerly known as BG12 or dimethyl fumarate. Basically, the exact mechanism, how it works, is not known, but it is believed to have an anti-inflammatory effect and also inhibits an enzyme that accumulates leukocytes, which are those white blood cells that attack whatever they think it's foreign, and at the sites of inflammation. And also is believed to reduce the oxidative stress, which releases the free radicals. And free radicals are what go and destroy, for example, when we age, as we age, free radicals is what those cells that go and destroy our skin, etc. Therefore, looking at more well, we can see then the effects of the years. So basically, it reduces the free radicals. There is a similar component used in Europe, specifically Germany, for psoriasis, and it's been used approximately like 30 years as the treatment of psoriasis in Germany. They did a trial with Tecfidera versus placebo, the DEFINE, and they showed a 53% reduction in the annualized relapse rate and 90% reduction in the mean number or new lesions or enlarging lesions at 2 years. The most common side effects are flushing, a sensation of like redness, discomfort, and like itchiness in the face, or some people in the trunk or the chest, headaches, nausea, vomiting, diarrhea, abdominal pain, among others, and it also does decrease the white blood cell count and can elevate the liver enzymes, so it's very important to keep an eye on that too. It's usually started at 120 milligrams twice a day with food for a week and then increased to 240 milligrams twice a day, unless recommended otherwise, and taking it with food reduces the risk of having the flushing. As I said before, it is recommended to monitor the liver and the white blood cell count. And we have to do white blood cell counts before starting the medication. And then the last oral medication also approved for MS is Elbagio, which was approved in September of 2012. It's also known as teriflunomide. Inhibits rapidly dividing cells, suppresses pro-inflammatory factors, and limits the proliferation of T cells and B cells. Teriflunomide is used also for rheumatoid arthritis. They decreased the risk of the annualized relapse rate by 30% in the studies that they did. Patients also showed fewer gadolinium-enhancing lesions per scan than those that were on the placebo group. And the most common side effects are hair loss, nausea, diarrhea. Also, it can be hepatotoxic or toxic to the liver. And it is a category X, meaning it's very severely dangerous to the fetus in the case of the woman getting pregnant. And also, it can be passed on in the semen from a man to a woman. So, other warnings is that it might decrease the white blood cell count. So again, it is recommended to keep monitoring acute renal failure, some skin reactions, peripheral neuropathy, and increase in the blood pressure. Now, some of the emergent therapies, but I'm sure like many of you heard last month, it was alemtuzumab or Lemtrada, which is an intravenous infusion. Also, a monoclonal antibody used for the treatment of lymphocytic leukemia and T-cell lymphoma in the past, causes the depletion of the lymphocytes. Again, those cells that are in charge of attacking part of our immune system. Within an hour of receiving the first dose, the lymphocytes and the monocytes are no longer detectable in the bloodstream. It was not approved by the FDA last month because they were requesting more studies that showed that the benefits outweighed the risks. So it was not approved. Some side effects that you can see is autoimmune thyroid dysfunction, inflammation, destruction of the thyroid gland by our own immune system, mild to moderate infections like respiratory tract infections, UTI, herpes, or the famous shingles too, and infusion reactions. It needs monitoring, with CBC, quarterly TSH, or the thyroid checks, acyclovir for a month because of the herpes simplex, herpes zoster, etc., and needs monitoring 4 years after the last dose. We also have rituximab, which has been used in the past for treatment of rheumatoid arthritis and also non-Hodgkin's lymphoma. It's also a monoclonal antibody, and an intravenous infusion causes a rapid depletion of the B cells for approximately 4 to 12 months. Reduction of the contrast-enhancing lesions in MRI and also in the relapse rate, and also since it's an infusion, it can lead to infusion reactions, nausea, infections, and there have been some cases of PML described on rituximab. So basically, to conclude, there are several medications in the process, several trials going on to have hopefully even more treatment options in the future, and hopefully one day, rather than a treatment option, a cure. So we're definitely waiting for that anxiously, but we have to make sure that the medications that we have for the patients are not only effective but also safe. Safety is extremely important. Thank you. And then, as Stuart had said before, I will be coming back at the end for any questions or any concerns that you might have. So, thank you. Thank you for your attention.
All right, so next Before we get into our second speaker on the program here today, I want to introduce somebody new that's going to be doing a lot of work in the Miami area. Jennifer Falk. Jennifer, where might you be? Oh, there you are. So today I have the pleasure of introducing you to Jennifer Falk, who is a master-level social worker dedicated to the MS community of South Florida. The Neuroscience Centers of Florida Foundation, NSCFF, is offering her services to everybody, free of charge. Jennifer has an extensive background in coordinating care within our community for patients, their families, and caregivers. So it's not just the patient that could go see her. The caregivers can see her as well. Her resources include home health services, duromedical equipment services, equipment devices, assistance, and therapeutic programs and referral information. If you step inside the box, you can say something.
Thank you, Stu. Okay, thank you very much. As Stu mentioned, my name is Jennifer. I am the Social Work Programs Coordinator at Neuroscience Centers of Florida Foundation. We really encourage you to get involved, to stay active. We are currently enrolling. We still have spaces available for our quality of life study. If you haven't enrolled with us yet, we are enrolling outside. We have a table with a sign-up sheet. The quality of life study is very important. We're looking to show how important supportive services are here in South Florida, and it has been limited. We're working on that. We are linking people in the MS community with different services and different resources, aquatic therapies, therapeutic horseback riding, support groups, aquatic diving, so assisted diving. If you are interested in any of these things or feel like being a little adventurous, come see us. And we encourage you to get involved, stay active, and come see us outside. Thank you very much.
Thank you, Jennifer. So, by the way, I forgot to tell you all that you're going to be eating lunch while the program's happening. So if anybody has a question or something that you want to say to your server, instead of yelling out, "Hey, server," just put up your hand, all right? And let them see you, and this way you're not bothering anybody around you, okay? So next up, we have Dr. Rick Harris from Weston, and Dr. Harris is a psychologist, and I know quite a few people that he's quacked along the way. Shrunk, yeah, that's the word. Sorry, he got me all quacked up with that, though. So, thank you.
All right, I'm going to be the first to wish you a good afternoon. Stu had the pleasure of wishing you a good morning, and it's my pleasure to wish you all a good afternoon. Stu introduced me. I'm a clinical psychologist, and I've had the opportunity to work with many MS patients during my career. And I'm here today, and I wanted to thank Stu and MS Views for the wonderful work they do, and for our opportunity to be able to share with you our experiences and our expertise. All right, before I start my topic, I'm going to ask those of you that are family members, caregivers, friends, support people, if you would, just take a minute for me and just stand up so I know who you are. Let me see you. Okay, that's awesome. I want you all to look around, okay? Because I want you to realize something, is you're not alone. You're not alone in this as a family member. And on behalf, you can sit down, and thank you. On behalf of MS Views, and behalf of all the MS patients, we want to thank you all for all of your support, because you all really help us get through this. So thank you. Okay, it's real easy for me to stand up here and lecture to you and tell you about what the impact of MS is on the families. But I'm going to ask a little help today. I need some help. I would like to know what you as family members, caregivers, and significant others experience. What is the impact that MS has had on you and your family. So if you would, just raise your hand, I'll call upon you. Yes, ma'am, please. This woman up front said, okay, that's fine. Yeah, friends or caregivers as well. Said the unpredictability. I'm going to apologize right now for my spelling. I do have a doctorate degree. It's not in English or literature, and so I don't have spell check. So that's the only one. That's the one they gave me. So we're just going to do that. The unpredictability of the disease and the difficulty in making plans. What else? What are the other things you all experience that impact you? Yes, ma'am, back there. So for you, the demand, one of the impacts for you is that your life becomes unpredictable. Okay. So this would be the unpredictability of the disease, and we'll call the demands. All right, what else? What are some of the other, yes ma'am? I'm sorry, I didn't hear you. Change of mood. Are you referring to your change of mood or the change of mood of the MS patient? Sir, I'm really sorry we had to disclose that. What else? What else is the impact?
I'm always looking for a handyman to do something that he would do before.
Okay.
And there's some things that even if I want to do, I cannot do.
You know, this is an important issue.
Always looking for a handyman.
So,
anyone knows a good one?
Anyone have cards for a handyman?
When they're asking or saying something, we would ask you to repeat so that way everybody else knows what's doing. Thank
Okay.
you.
Yeah, this woman mentioned that the need for a handyman. And one of the impacts, we're going to talk about that, is basically change of roles, right? That there are some roles that have changed. Anything else that comes to mind? Yes, ma'am. Whoa. That's awesome. This woman mentioned the apprehension or fear of the future. What's going to happen? We'll call that fear because that's a reality. Anything else come to mind? Yes, ma'am. Okay. Mention the worry. Worrying about what's going to happen. That the family member worries about, am I going to fall? Fear, we'll just broaden that to worry. Absolutely. Yes, ma'am.
I'm not a caregiver, I'm a patient, but the economic aspect.
Wow. Another impact is the economic costs. Absolutely. Anything else come to mind? All right. Well, these are all very, very, very important and impact caregivers, and hopefully we'll be able to talk a little bit later in my talk how we deal with these issues, the impact, and what we can do as family members and caregivers to cope with these factors. All right, what we're going to talk a little bit about today is the impact of MS in the family. We kind of alluded to that. The challenges we face as family members and caregivers, how do we cope, the consequences, and also to talk about the resources in the community. And, I'm so glad to hear Jennifer, right, that Jennifer is available. And please, as caregivers, we don't take care of ourselves. And what you just heard is Jennifer Services is available to you all, and avail yourself of that. We'll talk about that in a little bit. So, certainly we know that the impact of MS on the family, and we've alluded to this in some of the things that you all have shared with me, is that MS is a chronic disease. It's unpredictable, it's expensive, it elicits emotions, it costs energy and time on the family. I kind of conceptualize and think about this, that MS is like the uninvited guest that shows up at our doorstep and that consumes every resources of the family and never leaves. And think about that. How many of y'all had that experience where family members come down and, overstay their welcome? And we know that's time limited, but we know how that impacts the family. And that's what MS does. It's a chronic disease that comes uninvited and affects every aspect of the family. It's unpredictable. Certainly we heard this morning about the unpredictability of the disease, and it's burdensome throughout the course of the disorder, especially when it's so unpredictable. We don't know when symptoms will flare up. We don't know when we'll have be in remission, and that in itself takes a toll on the family. And that's exactly what we saw, one of y'all shared, with the unpredictability. It's difficult to make plans. How do you plan a vacation? How do you plan a trip when you don't know if there's going to be a flare-up? And certainly, it costs time, money, family resources. It's energy and emotions. It's inexpensive. Medications are very, very expensive. Doctor visits, co-payments can be very, very expensive. We'll talk also a little bit about what you all as caregivers, what your profile is, and how this really, really affects you. We also know that not only does the diagnosis of MS have an emotional effect on the patient, it certainly has an emotional impact on the family members, the caregivers. And this is something we don't always talk about. We identify that the MS patient's going to go through a series of emotions. We don't think about the family, including children within the family, what they might go through. And you know what? And the one thing to understand is no matter what that reaction is, it's not right or wrong. We all are entitled to our own feelings, our own reactions, as is every family member. So remember that our emotions, whether we're a caregiver or within the family, are not right or wrong. Some of those emotions are loss, grief, anxiety, anger, shock, denial, confusion, isolation, fear, panic, sadness, are all common feelings that every family member may experience. Expected. They're not abnormal. Also, as we talked about, or someone brought up, that the impact is energy. It zaps the energy of the MS patient, as we heard earlier this afternoon, but it also affects the family's energy. It's a drain on the family's resources. There's constant changes, adjustments. We need to find alternative ways to deal with life situations. Time. We know that MS can slow the individual down, but also slows the family down. It's, again, making plans. We need to account for our time. All right, what are the challenges to the family in coping with MS? When we look at, when we look at MS, we certainly see that families have different styles of coping. And we develop these systems as part of our family. We learn how to cope with things, resolve conflicts within the family. And so often, it doesn't change when we have a chronic disease within the family. But that chronic disease can really tax our coping strategies. And as I said, most families develop their own coping mechanisms. And we've kind of, in our field, labeled different ways we as families cope. One thing we talk about is instrumental coping, or problem solving. This is where the family looks at a problem and they solve it. They sit down, there may be family meetings, etc., and we resolve the conflict or the problem by looking at solutions. Another way families deal with problems is they become emotionally reactive. They respond emotionally. They don't look at the problem. They don't look at what they can do about it. They just respond emotionally. The other coping style we see is active, and the last one is avoidance. And this is the one that a lot of families do. Well, it's not a problem. We won't deal with it. We'll just make like that an uninvited guest is not here. We'll make like it's not in the house and deal with it that way. And obviously, the most productive way of coping, we'll talk a little bit that, is the problem-solving approach. And we need to also recognize that I, within the family, deal with things differently than the whole family does. We all have our own individual needs. And so what happens is when there is a chronic disease such as MS within the family, it takes up so much of the resources of the family that individual members of the family's needs may not necessarily be met or addressed or avoided. And so families and members of the family, particularly children, may experience feelings of isolation, rejection, abandonment, etc. The other thing that's really interesting, families develop a rhythm. Okay? I wake up in the morning, I know what I'm going to do, I grab my cup of coffee, I read my paper, I take out the trash when I'm supposed to. My wife may do her chores. We've developed a rhythm, and we do that in families. We all have our roles, our responsibilities. We've developed that rhythm. And it's a day-to-day rhythm. It gets disrupted when there's a chronic disease in the family. And the reason why I'm pointing these things out to you is so you realize that this is not abnormal, and so that you can recognize it and not be resentful or angry, but recognize it, and then we'll talk about what we can do about it. Certainly, the most important component of healthy families is communication. And when we have a chronic disease, we see there's a disruption in communication of the family. Most often, one person becomes the center of the family. And so the communication between members gets neglected. It's critical that families learn to communicate and continue to communicate. So we'll talk about what we do about that, but I was really interested. Who are you all? Who are these caregivers? Who are the significant others? Okay? And this was interesting. 47% of you work full-time. 13% part-time, 11% are self-employed. So how does MS impact you, caregivers, individually? 27% had a loss of personal income. 46% were impacted negatively in their work life. 30% had to take time off. 15% reduced their hours at work. 16% needed accommodations, like having to work different hours. 10% stopped work. 6% were forced to change careers. 6% took a less demanding job. So what you can see is MS not only impacts the family, but it affects the caregivers individually as well. This was phenomenal to me. And this was really interesting too. I was fortunate, I was involved in the field of oncology and treating cancer patients, and was somewhat involved with a study at the University of Miami, and we were looking at the impact of the diagnosis of cancer on people. And what we found was, on a large percentage, much higher than we thought, that the diagnosis had a positive impact with those people. They started to reprioritize their life, change their life, evaluated their lives, and made changes in their life. Guess what? MS caregivers tend to be very positive people. How cool is that? You all are really positive people. Pat yourselves on the back. 44% of you in survey strongly agreed that you cope well. 47% somewhat agree. That is 91% of you all out there are saying you're doing okay. That's incredible. I guarantee you, if I asked a poll of people in the general population, are you doing okay? 91% wouldn't say, I'm doing okay. So you all have demonstrated some strengths that are just not seen in the general population. You have resources. Listen to this. 30% of you all have said that you strongly agree that you become a stronger person as a caregiver. 55% somewhat agree. So in general, 85% of you have said dealing with MS in your family has resulted in you becoming a stronger person. That's pretty crazy. So think about that. You know, so often we look at the negative effects of what things do to us. But I want you to think about this. 91% agree that you're coping well. 85% say you're a stronger person. That's what it takes to deal with this as a family member, a caregiver. Reframing this. Looking at what I can do, not what I can't do. And that is being positive. All right, what are some strategies that we can do for family coping? Remember that uninvited guest? Okay? That we said taking over the whole house? You need to say to that guest, no more space. You're only going to allow you to take up as much space as that is necessary. We're going to deal with you and not let us become overwhelmed by you. We're going to deal with the MS on a day-to-day basis. You're not going to take over our whole lives. You're not going to take over our whole house. You're not going to take over our families. No more space to that uninvited desk. We're going to put it in the closet. I just thought of a bad joke. No. No, you don't want to hear my jokes. The other thing that's very important in dealing with MS is we certainly need to recognize that MS affects the activities of the family. We need to try to allow the family to maintain as many of their normal activities as they can. We need to adjust. However, the individuals in the family need to make sure and continue to do their activities. We adjust. We bring, if we're going to the soccer game, we make sure we'll bring a chair for the MS patient. We'll leave a little early. Why? Because it may take us a little longer to get to that soccer field to walk to it. But we will not allow it to affect our activities because it's critical. Planning. Someone mentioned about the fear, the worrying. Very important for planning. So, for example, we're not going to, if we're looking for a house, we're in the housing market, we're not going to look for a two-story house. Because we know it's not a good thing to do. We need to make sure that we have a one-story house that's easy to get around. So we're going to plan, and we're going to take into consideration MS, limitations, and we're going to plan as a family. We're going to plan for the worst, but we're going to hope for the best. Planning becomes important. Someone mentioned that the unpredictability, how do we plan vacations? Well, you still need to plan, but you have to have contingencies. So what do? We buy traveler's insurance. So for a small cost, we are insured and we feel secure. So planning becomes very, very critical. Some tips. Becomes really important that the family learns about the disease. It becomes important that you have good communication. So often I'm asked, well, how do we tell our children? What do we tell our children? You tell them the truth. I sit with children all day long, and they'll tell me, oh, my parents are getting a divorce. Or, my dad's sick. And you do an interview with the family, and they go, oh, we're not telling the children. They know. The best way to talk with your children about the disease or family members is you ask them. It has to be age appropriate. The communication needs to be at the level of that child, or even that adult for that matter. So we're going to allow them to ask questions, and we're going to provide information at their level. We're not going to talk about brain atrophy or demyelination. They're not going to understand that, but they will understand a chronic disease. We need to keep balance in our roles and relationships. Again, if I'm an MS patient, may not any longer be able to hang the fan. Okay? So we're going to balance our roles and relationship in the families. I may need to be asking my kids to be a little more involved. They may have to take out the garbage. They may have to change their roles and responsibility. And as I said, hope for the best, plan for the worst. Don't give MS any more energy, time, or attention it needs. Make time as a family to focus on things other than MS. Make sure you have nights together, time together, where MS is not the focus, that there are other things and other activities. Take advantage of resources in your own community, such as support groups, such as social work support, etc. Wanted to just talk about a little bit how important it is that caregivers take care of themselves. There is a term called caregiver burnout, and it's very common among individuals who have been put in the role of caregivers. You all need to make sure that you have your own caring plan, that you take care of yourself, that you're able to cope with the day-to-day activities, that you create a community of carers to support yourself. I had you stand up for a reason, to realize you're not alone. Attend support groups. Get that support. You know, we always kid around and, you know, well, I don't want to burden someone and tell them what I'm going through. It's a burden to them. You know, it's important. Okay? It's important that you have an opportunity to vent, to get it over, off your chest. You need to take care of your own mental health. Understand it's okay to get help. Define the help you need and seek resources in the community. Stu, where are we at with time? Okay. So I may speak softly, but boy, you get me going. I sit and listen all day, and I go, how do you feel about that? Give me a microphone or a stage. I just love to talk. If I have one gift to give each and every one of you, and that is a philosophy I believe in life. And that is a philosophy that I think can help us get through everything. We've already heard from some of you about your fears, your worries about the future. And what my philosophy is to be here now. And that is to stay in the moment. When we think about time, and I want you to think about this when we're dealing with an illness, an unpredictable chronic illness, whether you're an MS patient, a caregiver. When we think about time, the only thing that exists is this moment. The past doesn't exist. It's gone. There is nothing I can do about the past. The future doesn't exist. It hasn't happened yet. We may plan for things, as you know. Plans are our own subjective reality. It's what we would like to see happen. And so often, it doesn't. We don't have control over factors in the future. So what we do have control over is what? This moment. Only this moment. I don't have control over anything else except this moment. If you can live your life moment to moment, you will have better control of your life, and things like MS won't affect you as much, whether you're a caregiver or a patient of MS. Thank you.
So this is going to get us to a fun part of the program, okay? And I say this because we're going to do Q&A. You all going to help me lose weight today, all right? Because I have to get around with this microphone so that way I can hear your questions being asked. So the more questions you ask, the more calories I'm going to burn. Okay? So where are we going to begin? I have a question at this table, I know.
Okay, Dr. Fonseca, you work, I think, with Dr. Steingold? No. Okay. Well, anyway, do you recall the vitamin D levels, the optimum vitamin D levels in the blood? And I think there was another vitamin B12. Could you give us those that information, or write it on the write it on that board? Because there's levels.
Well, yes, for vitamin D, the actual level that you see The normal range is between 30 to 100, but really for MS patients, we recommend it for it to be higher, approximately 60, 70, up to 80. The better that vitamin D is, the less activity we see with MS. So the lower it is, the more activity you can see. So we want it to be actually on the higher, within the normal level, but 60, 70, 80. That's the blood. When you check for your vitamin D25, it's a blood work. And then
You have how much to take every evening?
it really depends on how much that person has as their baseline.
You have to retest it.
Yeah, you have to retest it ever so often and check on it, yeah.
What blood test is that?
It's a vitamin D25 level. Vitamin D25. D25, and it's just a regular blood test. And then based on the range that person has, I don't know, for example, 40, 50, whatever, then we recommend whatever vitamin D supplementation in order for you to get to that 60, 70, 80 range.
I'm taking 2,000 a night. Is that like you have to test
You would have to test your blood, yeah, to see how it is, because we don't want to be toxic either, so that's why we have to be checking constantly.
If I can make a suggestion, there's an organization in Broward County called Life Extension. It's on Commercial and Federal Highway, and you don't need to go to a doctor. You just pay for the test,
Okay, great.
and you can monitor it yourself, and they
Perfect.
sell the vitamins to up it, and they have very good health counselors.
Great.
The second blood test for vitamin deficiency, is it B12?
B12, yes, you
Okay.
also can check for vitamin B12. The normal range is between 200 and like 1,000. From the neurological standpoint, we prefer for it to be over 400, 500. Again, you don't want to be toxic on any vitamins, but that is also easily checked with a blood test for a vitamin B12 level. Easily checked, yes.
Next question is from over here, this same side. They're making it easy on me so far, but I see I got to run to the back after.
Yes, doctor.
Yes.
In your opinion, when is it best to switch or think about changing medications?
Okay, perfect. Well, that's a great question. The question is,
sorry, you can.
no, sorry.
The question is when do you know it's best to switch your medication?
Okay, and that is a very common question that we get asked a lot. Our recommendation, my personal recommendation is always if you are on a medication, X medication, that medication, you're able to tolerate it well, you're using it as it's supposed to be used, and you're getting your follow-up MRIs, your follow-up neurological examinations by your healthcare provider, and everything seems to be stable, I recommend for that patient to continue on that medication that they're on. There's really no recommendation specifically on when to switch. We switch, for example, when somebody's not tolerating a medication, or when someone is having exacerbations and they're using the medication as they're supposed to, or we see that they have accumulated X amount of lesions from the last time that we checked to today, or their neurological examination looks worse, then we recommend switching because apparently that patient is not responding well to whatever they're on, and therefore we recommend a switch. But if the patient is doing well, they're taking the medication as they're supposed to, they're tolerating it well, they don't have any issues, clinically they look stable, radiologically they look stable, my recommendations is to continue on whatever you're on since it's working for you. We don't really want to fix something that's not broken. So it's something that we all have to keep in mind. Thank you.
Thank you.
Thank you.
What is PML?
Oh, PML, yes. We had that question from before. PML is called progressive multifocal leukoencephalopathy. It's a massive demyelination of the brain, particularly obviously the white matter, which is the part that has the most, which has the myelin. There is a virus that many people can get in contact or can get it, which is called the JC virus. And that virus, for the most part, is just dormant. It's just there in their central nervous system. It really doesn't do much. But in certain situations where the patient is immunocompromised or their immune system is really, really low, that virus can flourish, start dividing, and then affect and infect the white matter in the brain. That is one of the potential risks with Tysabri, just because of the fact that Tysabri does suppress your immune system. It closes down the barrier in the blood and between the blood and the brain. Therefore, if that virus flourishes in the brain or starts dividing in the brain, your immune system cannot travel into the brain to defend you. So that's why there have been over 300 in some cases of PML throughout the years of Tysabri treatment. Obviously, the more, for the longer period of time that patient might have been on Tysabri, the more at risk he or she is. And also, it has to do with the JC virus antibody. There's some people that are JC virus negative, they're not going to have PML, but there's some patients that have JC virus positive, those need to be closely monitored. And even if you are JC virus negative, if you're on Tysabri, you need to be constantly rechecking that, since you can get infected with the virus at some point and not really know. So it's just a virus that we can come in contact with at some point and have it in our system. We just don't know, because nobody usually gets checked for that unless they're going to go into Tysabri or they're in Tysabri.
Wait. Just so you all know, everything that you want to know about PML, Stacy, is on the website as well. You can go there, and this way we can get on to the other questions. All right, because I do need to get around the room. By the way, everybody, there are microphones all around this room, so you guys are talking among yourselves, and it could be heard on YouTube. All right. So I just want to let you know that we really need, like I asked you about the cell phones, vibrate or silent. All right, we really need you to do that during the rest of the course of this program, please. And one final thing. General questions are great. Please don't ask anything that's going to concern yourself, because neither of the doctors can answer about what's going on with you unless you're actually a patient of theirs. Okay? Thank you. Let's continue.
Going back to vitamins, my husband is on B12. But I've always heard that when you take the B vitamins, there should be a balance of the other B vitamins. So would it be, appropriate to add the other B vitamins in addition to the B12 that he's been prescribed by his neurologist?
There are vitamin B complex, which basically have B1, B2, B6, B12. There's usually no problem taking those, and they're pretty good. Again, the vitamin Bs are the ones that are good for our central nervous system mainly. So if the patient doesn't have any major contraindications to having them, they can certainly take vitamin B12, B complex. Some patients are a little bit more deficient on specifically B12, and therefore we either recommend it for them to get it intramuscular with injections every month or every 2 months or whatever, so depending, so that we bring up that vitamin B12 since it's the most commonly checked. But for the most part, patients can take B complexes if they don't have any contraindications, and that's also another possible factor. Thank you.
A question was put to me for the psychologist. A caregiver wants to know when they could possibly know when they are being too much of a burden to the patient, that they're doing too much hovering over them.
Ask them. Good communication. Ask.
That was too short.
I know.
You don't deserve any other questions.
I appreciate the question.
Back in the back of the room.
Do you know of any relationship between MS and PAD?
No, between peripheral artery disease and MS? No, not specifically, obviously. Peripheral arterial disease, basically, some patients maybe with MS, if they're not able to exercise accordingly, or maybe, I don't know, get enough circulation going to their legs, maybe they can have a little bit of venous insufficiency, some swelling of the lower extremities due to lack of movement, but not specifically because somebody has MS is going to get peripheral arterial disease.
And do you know of any patients that do have both?
I do have some patients, but they mainly have other comorbidities like cardiovascular disease and other things, so we attribute that PAD to possibly something else.
Any other questions? Maria? Front of the room. Good. It's a shorter route.
I wanted to know if the doctor is familiar with PBA.
Yes, PBA, or pseudobulbar affect, or emotional incontinence, yes.
I know it's only affects about 10% of MSers. I have that, and it's very difficult to control without medication. Do you feel that someone should be on medication if they have PBA, or?
PBA, as I said before, pseudobulbar affect or emotional incontinence is basically, it can affect patients with traumatic brain injury, strokes, multiple sclerosis, and it's basically a inability to control, let's say, their emotions appropriately, meaning that maybe, for example, in a situation that's a serious situation, that person might be laughing, or vice versa, or maybe like a nice, happy occasion, that person might be crying, usually not really unprovoked, right? It's an inability to control one's emotions. So basically for that, there is medication approved specifically for PBA. It's called Nuedexta, and it was approved a couple of years ago for patients that have PBA. Also, so if that patient doesn't have any contraindication to that, they can certainly go on treatment. Also, psychological help, etc., might work. Therapy, because in some occasions it does interfere a lot with a patient's life. It's hard for them. Maybe they feel embarrassed, or maybe in certain situations they're basically, again, ashamed of their inability to control, maybe if they're at work, maybe it's inappropriate. So certainly for those that this PBA is affecting their life, I would probably say they don't have any contraindications, they will benefit from the medication. And again, maybe psychological therapy and other things. So definitely it's a situation that is not as common, but it can happen, and it can be very disabling. Thank you.
All right, we have a new question back here.
Hi, Dr. Fonseca.
Hi.
Could you tell us what you know about stem cell research, specifically between adult stem cell research and umbilical stem cell research?
Well, I'm not too familiar with stem cell research. I obviously don't perform stem cell research or in my clinic. With stem cell, I've found it's... I have some patients that have gone for stem cells, and they have, my personal opinions, they have not seen any great benefits. I know of other patients that have, so I guess it really depends. Again, I'm always very concerned about that, since patients should do it if they are to find out about information in places that are trustworthy and that they're serious places, because we don't want to end up somewhere that they say that they're doing some stem cell research and then for it to be, I don't know, something else. So it's something that needs to be taken into consideration and very carefully, as at this point I don't particularly recommend stem cell infusions or transfusions due to the fact that it's not an approved treatment. It's not a treatment that's approved by the FDA or anything like that. So I personally don't recommend it. But I guess there's some patients that are actually, they want to find out a little bit more about it. And I know there's certain places here in the United States that actually do it. But I don't know here in Miami, to be honest. But there's several places up north in the Northeast that I know do stem cell research and stem cell infusions. But it's a double-edged sword. You have to make sure that it's in a place that where you go to find out information is a trustworthy place. That sometimes, there's people taking advantage maybe, and it's a very expensive treatment. So I encourage patients just to find out really what it is, what's all behind it, if it's a serious place. But at this point, I particularly don't recommend it.
Given the news lately that we've all probably been hearing, please tell us about the legitimacy of marijuana with respect to multiple sclerosis.
Okay, marijuana has been found to be a very good muscle relaxant. It helps with spasticity, muscle spasms, helps calm people down, etc. Obviously, it does come with a price. The price, mainly, at least from my standpoint, is that it can affect long term, and if used, if it's used chronically, let's say for an abused memory. So it's very it has to be, you know, taken into consideration as well, because we don't want to have no muscle spasms, but then our memory to be affected to the point where we can't properly function or function as we would. And we know that MS in some occasions can affect cognition and memory, so we want to make sure that we don't expedite that by using and abusing the marijuana. So it's used for as a muscle relaxant. It's used for calming down, but there's other options than marijuana to help muscle spasms, muscle relaxants, etc. It is not FDA approved for sure. No.
And it's not legal.
Yes, and it's not legal, at least here in Florida. No, it's not legal here in Florida.
No, Florida is supposed to be putting it up for a vote.
Yes, supposedly they are.
All right, question up front, please.
This question is for Dr. Harris. From the caregiver point of view, to assist the caregiver, we know that there are issues with isolation and depression related to MS. And are there any general tips that a caregiver can learn to use when dealing with someone who is isolated and depressed? I mean, other than the medications that are prescribed.
Yeah. First of all, we heard that, you know, depression is a very common symptom of MS. So really important that an evaluation is done to find out, is the depression secondary, primary, and so often we call sadness or a normal reaction to what's going on depression. So it's important to have that assessment done to make sure that it really is depression. And certainly medications can be appropriate. I have seen some incredible work with nutraceuticals and depression. I'm a real advocate of nutraceuticals in treating depression. We in our facility, we're an Amen professional clinic, so our first line of defense is nutraceuticals first, but certainly antidepressants can be appropriate. As far as the isolation, if the isolation is secondary to the depression, we better treat that first. And if it's isolation because of some other issues, fear or anxiety about going out or embarrassment, certainly trying to get to a support group. We heard that, you know, at Doctors General, there's the support group, a social worker, a psychologist, but certainly to get to a support group so that that individual who has MS does not feel isolated or alone. Coming to an event like this, I mean, look around this room. I mean, this is amazing. You know, that we're able to have this many people who have MS come together and learn. So it's really important to encourage them to get out, but an accurate assessment is real important.
Middle of the room.
I was thinking about the drug that this young lady just talked about for MS patients, the marijuana. Well, if we, I know we don't want to take it because it has a lot of side effects like our medication does now. But think about it. You might be voting for it next year. It might be on the ballot, so get all the information that you can because it's going to be out there.
Was that a paid political announcement?
I think so. I think so. You know, from the internet, I was given questions to ask at today's program, and what did I do? I left all the questions home. But one of them I remember, and that is that the person wanted to know about the neuropsych exams. What is done at this exam? How long is the process? Recently, it was announced by somebody on one of our Facebook pages that she went through a 3-hour exam for a neuropsych exam. And other people are mentioning that they've only done it for a few hours, and other a full day. Can you tell us what the process is?
A neuropsychological evaluation is performed by a neuropsychologist. And what we're looking at is we're looking at various behaviors, and we're making inferences about brain behavior relationships. So, for example, there are different areas of the brain that cause different behaviors. So by measuring those behaviors, we can determine areas of the brain that may not be functioning up to their potential. The reason why one person may go through a 3-hour exam, someone a 4-hour exam, is the exams are dependent upon the symptoms presented and also their progression. So we may do what we call a mental status exam, and we'll see there's a memory deficit. So we're going to want to find out what kind of memory deficit is there. So the exams are dependent upon the symptoms presented and the problems that need to be addressed.
Do we have any other questions? What are nutraceuticals?
Vitamins.
Vitamins.
Supplements. It's the new fancy word that makes me feel important.
Like I'm not allowed to say videotaping anymore. I can't say we're videotaping. I can only say we're video recording.
Actually, the difference between nutraceuticals and vitamins or supplements is that nutraceuticals, there's some strong research to support their use as opposed to just going to Walgreens and buying a vitamin. The nutraceuticals have some research basis to them.
Another quick question. Cognition. What do you suggest for people to do to help them to remember things, note-taking and other things?
What'd you just say? Oh, cognitions. Really, that's a question of memory, not just cognition, because cognition takes and encompasses a whole realm of behaviors. But certainly, memory is really important, and you made some really good suggestions. Is write things down. I got this phone that does all kinds of stuff that I'm just learning how to use it. I can use it to record things, so I can talk into it and remember putting things where you put them. Routine can be so important for memory. Structure, doing the same thing every day at the same time.
Don't you have to remember where you put your recording device?
And then a good sense of humor, so that it doesn't get to you and you kind of like just accept it, as Stuart did when he said, remember, I have MS, I don't remember that. To really be able to laugh and not take things so seriously.
How do I know if my memory is being affected by MS or there's a possibility of dementia, not from MS, or a possibility of early stage Alzheimer's? I found over the past 20 years, my memory is kind of lackadaisy anyway. But I also found that somebody said to me that there's if you forget, you put your keys someplace, you put it down, but you forgot where you put it. There's a way you can tell. There's a way you can tell if it possibly of Alzheimer's kick, or is it possibly just a memory loss, or just could have been the drugs from 25 years ago. I don't know.
It's marijuana. Certainly that you mentioned Alzheimer's and dementia. There is a bunch of symptom complexes that are also associated with just the memory loss. So again, it becomes really important to have a neurological consult or a neuropsych eval that can help differentiate what is that memory loss. Is it short term? Is it long term? What areas of the brain are involved? So, and what other symptoms are you experiencing? With Alzheimer's, you're just not having memory problems. There's a whole complex of symptoms. So it's really, again, important to have a consult your neurologist first and talk about those things, if you can remember.
Well, I can go back, just real quick. I can go back and, 25 years ago, I've done things I can speak really loud. 25 years ago, I've have done things that I get reminded that concerts, but besides concerts, going out to dinner, going different places, vacations, a lot of things that are blanked out of my mind. My childhood is gone. Most of the stuff in my childhood is gone. But then again, I had I had MS in my family when my mom had MS. So I blanked out a lot. I maybe blanked out, or maybe I forgot. I'm not sure. So there is a definite complex of things going on.
Well, that's why an evaluation or consult so important, is to put that in perspective. Is it the MS? Is it the trauma as a child? Is it concerts? Is it whatever? You speak to your neurologist, who happens to be experts in memory and memory loss and forgetfulness, and can help do a differential diagnosis. And they'll refer for a neuropsych eval or memory test. There are all kinds of ways to assess memory functioning. And so often, the normal process of aging, we do forget things. We do lose memory. How often if I can just defrag my brain, or if I can find an external hard drive for it, I'd be really in good shape. So the normal process of aging is we do tend to forget things. There's only a limited amount of gigabytes up there.
All right, question from the back is, with multiple sclerosis, which is affected greater, short-term or long-term memory? We're getting a collective answer from the audience.
I would probably say it's more short-term. This is the short-term multitasking abilities. Those are the concentration. Those are the things that get most affected with the majority of the MS patients. Short-term concentration and multitasking.
Can you differentiate that? Because I know the brain's really complex. Short-term versus Alzheimer's. If you just have short-term memory loss, is that Alzheimer's or dementia?
No, not necessarily.
Let me clarify the question. If you only have short-term memory loss, do you have dementia or Alzheimer's? Only. If that's your only cognitive problem.
The thing is that short-term memory can be affected by many things, including MS, including dementia, aging, normal aging. Depression, which is a very common cause of pseudodementia, which I have mentioned it before. Sometimes it's even metabolic things like vitamin deficiencies, thyroid.
What I'm saying is, does dementia and Alzheimer include more things than just short-term?
Certainly, yes. Alzheimer's, and which is the most common type of dementia. Dementia can happen because of other reasons, strokes, etc., which is the famous vascular dementia. It is a group of symptoms. Patients just don't show up because they forgot a couple of things that had happened recently. It is a group of symptoms. Sometimes they present short-term memory loss. Sometimes they present episodes of confusion, disorientation. Sometimes they don't recognize family members that have been around them. Sometimes they have difficulty doing activities like they were used to, like getting dressed or feeding themselves. So it's like a whole bunch of symptoms that then you take into the concept of a fact that it's a elderly person, and you've ruled out a bunch of other things, and therefore it looks more like it's Alzheimer's, which is, as I said before, the most common type. But certainly not in somebody that has short-term memory. It has to be dementia. It could be a bunch of other things.
I think a lot of people, even people without MS, have this underlying fear. A lot of people, even without MS, have an underlying fear that every time they lose their keys, there's so much in the news about Alzheimer's. That, oh my God, I'm going to get Alzheimer's.
Sure.
And this is horrible fear. And you just lost your keys, your hard drive is full, you have too much on your mind. And,
Correct.
I think if we were alleviated of that fear, it's a great relief.
Sure. And for that, as Dr. Harris had mentioned, a neurological evaluation, neuropsychological testing, all these other things help. Sometimes it's maybe a medication that you're taking that's, I don't know, you feel a little bit foggy and then you forget, or maybe your concentration, you have problems with concentration, so you don't forget what happened recently because you weren't maybe paying a full attention. So it's many other possible problems, but not necessarily Alzheimer's.
Question. Other than speech therapy, what would be good for a person with difficulty in speaking to do?
There's no specific medication, so I think speech therapy and the exercises that they can teach patients to do maybe at home is really the most, will be of the most benefit to that patient that has a speech difficulty, because there's nothing specific for speech problems. So I think speech therapy will most likely be the main recommendation. Yes.
On the speech therapy aspect of it, I have a hard time with word finding sometimes. But I was told that if we do things like games like categories and things like that, that will help us.
Sure, there's certain games that speech therapists can actually recommend. Puzzles, word, one of those things that you circle the words, all these things can help, the word search, all those things can help. We're finding difficulties. Sometimes they're just a natural process from the MS. Sometimes it's even worse than by certain medications. So that's also something to keep in mind. There's certain specific medications that are known to cause word finding difficulties, but certainly speech therapies can help. One of the tricks for those patients that have word finding difficulties is that for the most part they will get a little fluster when they're trying to come up with the word and they can't, and that will certainly just make things worse. So definitely the speech therapists can provide certain little tricks to help with that matter for you to slowly feel better and get that more controlled.
Okay. There's a question that's coming from a person that wants to know if they're being prescribed something that they're totally against doing, what should they do?
Okay, well, I guess the only way to do would be to sit down with their healthcare provider I'm sorry, and discuss why they're against it, what are the pros and the cons of that. But ultimately, we can make recommendations, but that patient or that person is the one that will have to do it. So if somebody wants to make me do something against my will, obviously that's not going to happen. So you certainly have to sit down and talk to that healthcare provider that recommended something that you're totally against, and actually have a frank conversation with him or her and really present all your opinions, for him or her to present all their opinions, and then maybe to reach or get to a happy medium. But certainly I don't recommend anybody doing anything against their will. They have to understand why they're doing something. Specifically in examples of such as treatment, you have to understand the risks, the benefits of a treatment, what the treatment entails. Nobody can really force you to go on treatment. It's really a matter of it's an agreement between the physician, the healthcare provider, and the patient.
Okay, do we have any more questions? There's new people in the audience. I'd like to know what they have to say. Hold on.
Bottom Line Books had an article about coenzyme Q10 helping people with multiple sclerosis. Have you had any experience with that at all?
Yes, coenzyme Q10 for multiple sclerosis and for other neurological diseases such as Parkinson's disease and Alzheimer's. Certainly, if there is no contraindication for that person to take coenzyme Q10, they can certainly talk to their physician and recommend it. In some occasions, I do recommend it a lot. So it really depends, obviously, on each person, but it's something to certainly talk about to your healthcare provider to see, because they have shown, coenzyme Q10 has shown benefit in multiple neurological conditions, including MS and Alzheimer's and Parkinson's.
Okay, any more? No. I see we're running out of questions. No more? One more? No, you got to wait. This is the last one.
We spoke about stem cell. You know, my daughter had a baby about a year ago. We did stem cell. We did the cord, and we also did the blood. You know, we can hold on to it for 30, 40 years, whatever. It's very expensive. What are your thoughts about this? And also, well, let me go a step further. It's not going to be good for me, for my MS. It's not going to be good for, from what I understand, if a stem cell happens to come into play at some point with this, with the blood cord and all that, it's only going to be good for her and possibly for Madison, the daughter.
Yeah. Okay.
And that's as far as it's going to go in the family.
Sure.
So,
Or for those patients that have the financial capabilities of doing the cord that they take it and they take the umbilical stem cells from, that's no problem. I actually think it's a great idea, and certain patients, hopefully, and certain people can help them if they develop some sort of chronic problem. I don't know, like a cancer or a malignancy or something. So certainly for those that can afford it, most definitely. I'm not against those umbilical cord stem cells and maybe saving it for that people for 30, 40 years or whatever they're saving it for. I don't have any problems. My problems is more of a MS patient just relying on stem cell treatment as their option. That would be what I would be against. I would certainly not recommend that. But for saving, now that we have that option, before we didn't have that option of saving the umbilical cord, but whoever that has the financial capabilities of doing, why not?
Thank you. Doctors, thanks to both of you for coming out today, assisting with this program, speaking at this program, and I want to thank everybody that's here for coming today. Yeah, you will. Listen, if any of you have questions for either of these doctors after the program, you could send me an email. I'll send it to them, and I'm going to ask them to respond directly to you, so that way I'm not the monkey in the middle. All right? Thank you. Thank you. Thank you. Thank you. Thank you. You're going to pull numbers, aren't you? Who's going to pull numbers?
go Denver!
Go Seahawks.
That's why I said go Denver.
All right. We got two things to give away today. One is a Shell Oil gift card for some free gas for you so you can get across town for the next few days. And the other one is what's called a power bank. And this is a little device that when you hook it up to your computer or elsewhere with a USB port, it's extra power for your cell phone. So that way if you're out and about, nowhere near a charger, ladies, this is great to put in your purse. Guys, give it to the lady that you're with to hold for you. One has nothing to do with the other. All right. I'm going to ask our new social worker for South Florida to pull two numbers. Jennifer.
Okay. We have 366678.
You got to prove it. Who has 678? You do. Good. All right. And the next number?
366658.
658. 658. Wow, we got one from both sides of the room. Where's 658? Both sides of the room wearing the same color. Same color hair, same color shirts. What does that mean?
Thank you very much.
There you go. And this is for you. Thank you for coming to the program. Everybody, our next program in Miami is May 13th. May 13th, we're going to do a program right here at this facility. I don't know if it'll be on the side that you used to go into, in the Doral rooms, or over on this side in the Akasha room, but we want to thank the Intercontinental for allowing us to do this program here today as well. Thank you again for coming, everybody.